in 2003, member states called for a revision of the IHR, which prior to 2005 had not been revised since 1969. So in 2005, the member states of the World Health Organization looked at revising this legally binding commitment among what is now 196 state parties to think about early detection and rapid response. And this was really in response to some of the failures in reporting and timely response to the SARS epidemic, which did lead to the outbreak spreading to over 20 countries and leading to over 8,000 deaths worldwide. It entered into force 2 years later in 2007, and what it acknowledged was, and what was important to call out, particularly in this revised framework, was that public health incidences pose threats beyond national borders, and that states parties within this operation bear responsibility to identify, report, and when possible, contain public health threats before they become what WHO qualifies as a public health emergency of international concern. So what did state parties agree to when they signed up for the international health regulations? It really is, and this is just an example from a number of articles and annexes within the framework, looking at really developing core capacities for meeting the minimal requirements to detect, assess, report, and respond to public health events, to be able to communicate effectively both within either a WHO region or the global community through the nomination of what are called international health regulations focal points, which can be individuals or members of an office that are available 24/7 to be able to communicate within and across sectors. Thinking about strengthening points of entry in terms of disease detection and control, particularly at designated points of entry, whether they be land, air, or sea. And then developing a framework for notifying WHO within 24 hours of a potential FEIC, or public health emergency of international concern. And this was a big sticking point, particularly based on the SARS epidemic in 2003. And there's a number of aspects calling for collaboration, both technical, financial, or logistical, and then a requirement on an annual basis to conduct a self-assessment and report to WHO on the ability to comply with the international health regulations. The IHR, in its monitoring and evaluation, as well as the core capacities that it identifies, really looks at three-phased approach, building up not only at your national level, but thinking about both intermediate and local level capacities. And it's a capabilities-focused needs assessment, thinking about what are priority events, both priority diseases from an epidemic or emerging perspective, as well as other threats outside of infectious diseases, chemical, nuclear, radiological, or high-impact public health issues. They then identify capabilities for prevention, detection, assessing, reporting, and responding, and then identify activities at each of those levels, national, intermediate, and local, to identify how best to prepare and respond to those. And then identifies what the needs are at those levels to be able to have the capabilities to respond to those types of priority events, whether that is infrastructure, human resources, equipment, material, reagents, et cetera. One of the challenges stemming from 2007 to today is that there was really an unacceptable slow progress towards IHR capacities. When we think about a number of international health frameworks, IHR is a legally binding mandate. So those 196 state parties who signed up and are now required to enforce the IHR had a very hard time meeting all of the core capabilities. And what seemed to be the problem were kind of really at three different levels. It was a low priority outside of the ministries of health in a number of countries. And so there was a lack of awareness from political leaders across ministries and from a whole of government approach. So it was very sector restricted. And there were fragmented objectives and milestones that created program silos. That, as a result of bilateral, multilateral engagements, donor-recipient relationships, and the priorities of health funding occurred to promote IHR compliance. So in response to this lag in building up capacities for the international health regulations, the creation of the Global Health Security Agenda occurred. And the idea was not to recreate the wheel and not to duplicate any efforts, but to build on IHR and provide a platform to encourage better compliance. And so it looked at raising the profile of global health security issues beyond the Ministry of Health and think about a multi-sectoral, multidisciplinary approach to global health security issues and create shared milestones and goals for all of the partners involved so that there could be a systems approach to this capacity building. The Global Health Security Agenda was launched in the U.S. In February 2014, actually during a snowstorm in D.C., where most of the government was shut down, but the Global Health Security Agenda was launched that day with a number of international partners, as well as WHO, FAO, and OIE in support. And what it looked at, and you'll see these are very similar to the IHR, is thinking about preventing avoidable catastrophes, detecting threats early, and then responding effectively and rapidly. And so, as I mentioned before, it was really looking at how to accelerate implementation of IHR and other health security frameworks that already exist, advancing progress towards a world safe and secure from infectious disease threats, looking at building up multi-sectoral efforts for commitments and capacity building, and then elevate global health security as a priority for leaders worldwide. So not just the health sector or even the agriculture sector, but thinking about trade, economics, travel, transportation, et cetera. So in, I think to date, there are about 67 countries that are signed up as members of the Global Health Security Agenda. And the vision really across GHSA, when it was founded and established in 2014, was to think about, again, as I mentioned, attaining a world safe and secure from global health threats posed by infectious diseases. And that infectious diseases, and particularly epidemics, pose not only a local threat, but an international health security threat. So aligning that very closely with requirements under the international health regulations. And that it's very important to acknowledge that no nation can achieve health security on its own, and that this should be a collaborative process across the member states. And so looking at how to track progress, because this was one of the challenges under the IHR, was that under the IHR, there was a monitoring and evaluation framework that state parties were required to do on an annual basis. Many times it was done only through ministries of health and agriculture based on interest and relevance in reporting structure, and didn't always capture the full capacity of that country. And so in response and through the Global Health Security Agenda, the Joint External Evaluation was created. And this is a process where, a voluntary process where states parties can sign up for an external evaluation by a number of subject matter experts across 19 technical areas for countries to be evaluated under this Joint External Evaluation tool, which is aligns with IHR and priorities under GHSA. And this occurs every 5 years. So a number of states have implemented and undergone both their annual reporting and the JE assessment. A number of these reports are freely accessible online to download and review. And there are a number of countries that are coming up on their 5-year renewal for the Joint External Evaluation. Following the JE, there are 2 other steps in the process, thinking about an after-action review and a simulation exercises. So countries are able to review how the external evaluation went, think about plans, policies that need to take place, and then run simulations on a potential realistic outbreak to test the policies and the frameworks that they have in place. The idea being, of course, a plan on a shelf is a plan on a shelf. You need to take it off that shelf, make sure the parties that are outlined in your SOPs and in your call to action know that that's their responsibility, that they are practiced, and you have an opportunity then to revise and revisit your plan so that when an event occurs, you are fully prepared. Ultimately, countries are asked to develop a national action plan for health security. This aligns with budgeting and allocation for resources and for steps in building towards IHR and global health security compliance. through 1 year and 5 year plans. Getting into biosafety and biosecurity, of course, an important topic for all of us here today. This is something that, of course, and I'm sure a number of you have seen this fantastic graphic before. We think about, of course, biosafety from a risk assessment perspective and biosecurity from a threat assessment perspective, and the range of vulnerabilities across those two disciplines. Biosafety and biosecurity are a key part of both the IHR and the Global Health Security Agenda. And it is its own by what we call action package under the Global Health Security Agenda. And it is the one of the action packages under the prevent bucket in the Global Health Security Agenda. And in the creation of this action package, some of the acknowledgments for the importance of biosafety and biosecurity from a global health security perspective are the consideration that especially dangerous pathogens can be identified, held, and secured and monitored in a minimal number of facilities. So thinking about the facility security, institutional biosafety, and biosecurity required for the handling and storage of especially dangerous pathogens. That biological risk management, training, and education are critical, and that country-specific biosafety and biosecurity legislation, as well as laboratory licensing and pathogen control measures, are important aspects to a nation-state's health security. So when we think about the role of laboratories, particularly for biosafety and biosecurity in the Global Health Security Agenda, we, of course, know there's a need for safe and secure laboratories for disease surveillance and for infrastructure in terms of both research and diagnostic capability. We need to have rapid detection and containment of emerging threats. When we think about the number of emerging and re-emerging diseases that present like a acute respiratory illness or an influenza-like illness, diagnostics are critical when we think about how to characterize and confirm a disease threat. Most countries have limited core biosafety and biosecurity capabilities, and so how do we build that infrastructure? It's not just thinking about exterior safety and security, but the training of individuals and the retention of those individuals. Thinking about limited preparedness and prevention, detection, and responding to bioterrorism threats. When we think about how countries prioritize both funding and resources for laboratory safety and security, this tends to fall off radar or potentially fall off in terms of budgeting constraints. And then the lack of capabilities in areas that are vital to countering biological threats. So these are some of the key aspects where the laboratory plays a critical role in global health security agenda, primarily along biosafety and biosecurity. So the action package, Prevent 3, which is biosafety and biosecurity, in the Joint External Evaluation Tool is quite extensive in terms of what are the designated qualifications where you rank from no capacity to full capacity. And there are two major indicators under this biosafety, biosecurity package. A whole of government biosafety and biosecurity system in place for all sectors, including human, animal, and agriculture facilities, and biosafety and biosecurity training and practices in all relevant sectors, including animal, human, and agriculture. And just very quickly looking at sustainable capacity, so countries who get the top score have multi-sectoral biosafety and biosecurity systems in place, and they have adequate funding and political support for comprehensive biosafety, biosecurity systems, including maintenance of facilities and equipment from a whole of government system in place. And when we think about training programs at sustainable capacity, those countries have training programs that are included at a university college level, pre-training service, and continuing education. And that staff competence across laboratories is assessed and exercised as needed and conducted periodically, that the country has funding available to sustain these activities, and there's a review of training needs assessments that are conducted periodically, and training on emergency response procedures. So that, under the Joint External Evaluation Tool in support of IHR and GHSA, are what the framework outlines as sustainable capacity. Early on in the administration of the Joint External Evaluation Tool and support for the Global Health Security Agenda, there was a working group assigned to think about some of the top gaps that had been identified in those initial rounds of JE assessments under the action package Prevent 3, Biosafety and Biosecurity. And what they found overall, regardless of the region or the country that had been assessed, was that there were gaps in enacting comprehensive biosafety and biosecurity legislation. A number of countries had traditionally biosafety legislation that dealt primarily with agriculture, genetically modified organisms, but did not pull in the biosafety, biosecurity from a laboratory perspective. There were gaps in developing SOPs and guidance documents for research institutions. There was not a uniformity across the board. There needed to be increased biosafety trainings and national curriculums that could be established, conducting sample inventory and mapping laboratory systems, both at the national, regional, and local level, improving laboratory investments, accreditation, licensing, and then standardizing human, animal, agricultural biosafety, both across public and private laboratories. So these are gaps that were found early on and some that continue to exist to this day through the process. So the Global Health Security Agenda, when it was launched in 2014, was launched for 5 years. The Global Health Security Agenda is one of the policies that has been supported across different administrations in the U.S. and one that has gained and sustained support from the international community. And so in 2019, the international groups and the nation states that support the Global Health Security Agenda voted to extend for another 5 years. And so the strategy for 2024 really looks at advancing multi-sectoral approaches to health security, supporting adherence to international standards, both for human and animal health, identifying and addressing gaps and priorities in health security, and advancing sustainable financing. The action packages that are identified in the 2024 strategy are again across these 3 priority areas: prevent, detect, and respond. And you can see that under the prevent focus area, we have biosafety and biosecurity. And so recognizing that biosecurity and biosafety play a major role in terms of prevention and of avoidable outbreaks, accidental and deliberate biological threats. For the revised action package, the Biosafety Biosecurity Action Package really looked at advancing biosafety and biosecurity in support of a number of existing instruments. So again, trying to build this umbrella and link these frameworks together so that as nations buy into this process, they can see that the building capacity under Global Health Security Agenda not only aligns with the international health regulations, but the Biological Weapons Convention and UN Security Council Resolution 1540. And the 3 major strategic objectives under this action package is to think about full compliance with biosafety and biosecurity targets as outlined under the action package through WHO's Joint External Evaluation Tool, as well as the World Organization for Animal Health, or OIE's Performance Veterinary Pathway, the Performance of Veterinary Services, or the PVS pathway. And the idea then is to track actions and progress to achieve these targets, and primarily calling out specifically collaboration with NTI, or the Nuclear Threat Initiative, on the global biosecurity dialogue across 3 different focus areas: policy frameworks, capability development, and emerging biological risks. And the global biosecurity dialogue is an extension of the action package, looking at pulling together key ministerial leaders across a number of member states to the Global Health Security Action Package, and talking about multi-sectoral, multidisciplinary approaches to biosafety, biosecurity, outlining the priorities and also outlining the existing gaps so that there can be an action plan for how best to approach these issues. And then also looking at acting as a liaison between donors and recipients, pairing committed countries looking for support, and looking at partnering with existing groups like the Global Partnership Against the Spread of Weapons of Mass Destruction and the Biosecurity Working Group. And this will all tie into the Global Biosecurity Dialogue. So very quickly, just to mention the Global Health Security Index, which was launched in 2019. And this is the reports that actually President Trump displayed early on in the pandemic to indicate the U.S.'s compliance and readiness to respond to emerging threats and to pandemic threats. The Global Health Security Index looks at aligning efforts under IHR and Global Health Security. This is not a mandated or legally binding framework, but more looking at, do you have in existence tested, proven capabilities for stopping outbreaks at the source? So not just having the plan on the shelf, but have you actually used it, exercised it, and tested out whether or not it would be reliable in an event. And so the questions are designed to determine not whether just capacity exists, but whether the capacity is regularly tested and shown to be functional. And this is just a snapshot in the center of looking at the indicators that the experts developed. This was a collaborative effort across a number of different global experts in health security, creating both thinking about prevention, early detection, and rapid response. And you can see that biosafety and biosecurity are in that prevention area, and they have a weighted score of roughly 16%. And so this was an assessment done just through open source data, looking at what countries have available. And you can see from an overall score perspective, countries that are shown in yellow have what the index would consider met the capacity. So the U.S. scored the highest in the GHS index based on this assessment. And just to call out specifically biosafety and biosecurity, again, we can look from a global perspective on how countries ranked. Looking from a biosecurity perspective, again, you'll recognize some of this language from IHR and Global Health Security Agenda, whole of government biosecurity systems, biosecurity training and practices, personnel vetting, transportation security, cross-border transfer and end-user screening. The U.S. as well as a number of countries are in that yellow most prepared region. Biosafety, looking at whole of government biosafety systems and biosafety training and practices. You'll notice that there's pretty good similarity in general across the countries that ranked high in biosafety, biosecurity, and this is a nice indicator for understanding how best to think about promoting policies, practices, and programs to build biosafety and biosecurity under not only the IHR, Global Health Security Agenda, but from a global promotion perspective. We could argue that there were maybe challenges in how this was reported and the U.S. response to the current pandemic, but for at least for today, we'll focus on the biosecurity, biosafety perspective. Okay, so some of the lessons learned that we've had over the number of years through IHR implementation, and then from 2014 on under the Global Health Security Agenda, is that biosafety and biosecurity represent a key action package to meet the goals and objectives of a multi-sectoral, multidisciplinary approach to health security. The biosafety biosecurity action package really looks at advancing global biosafety and biosecurity through the creation and strengthening of national frameworks and systems. And since the implementation of the Global Health Security Agenda, there's been a significant progress in establishing and strengthening multi-sectoral systems, thinking about health threats. I think the Global Health Security Agenda has really catalyzed conversations across sectors about the importance of health security, not just in the aspects of emerging public health threats or emerging veterinary health threats, but then also thinking along that biological threat spectrum through more of the heavy security focused areas. And we've made a lot of progress, but there's still a lot of work to be done. And so thinking about, again, that sustainability aspect of partner buy-in, program support, international collaboration on biosafety, biosecurity will be critical in the coming years. I'd like to thank you guys for your time and attention, and just call out our fantastic team. The founders of the Elizabeth R. Griffin Foundation, of course, are the Reverend Carol Griffin and the incomparable Jim Welch, who are still key partners for us in the Griffin program at Georgetown. And I'd like to thank my research associate, Alexander Linder, for all of his efforts in the program in terms of providing support and promotion of biosafety, biosecurity, and occupational health. And happy to take any questions that you might have. Thank you so much.
Thank you so much, Erin. What a wealth of work being done, and timely, right?
Yes.
In a pandemic, for sure. I don't see any questions yet, but I'm happy to entertain any if there's some out there people are interested in knowing more about. Just take a look here. I'm not sure if I'm not seeing them all. Cindy, if there are questions, I think you have a super sleuthy way of seeing them.
I do have a super sleuthy way, but I don't see any questions.
Okay. Okay, well.
Wally, I do have a question. For some reason, I'm not able to go into the chat, or the Q&A won't allow me to submit a question, only an answer. So if it's okay, I'd like to ask Dr. Sorrell a question. I know that for some of us on this symposium participants, biosecurity may be either a new or an area in their profession where they don't get to dive in too much. Could you recommend for those of us where biosecurity may not be the first role that we take on, where, what are some good resources to start in with?
Sure. Yes. I think it's a great question because it can be challenging not only to think about how to prioritize from an institutional perspective, training and educational awareness on the importance of biosafety and biosecurity, but even the kind of combination of the two when we think about biorisk management. There are a number of really great handbooks on biosecurity that, Wally, if it's possible, I'd be happy to share links to.
Absolutely.
So that the members could have access to them. A couple of really great links and websites that would be fantastic resources. I'd be happy to send those over so that everyone has access to those. I think biosecurity can be a challenging conversation, particularly when we think about institutional biosecurity, thinking about how as an individual we can be responsible, and then as a group, how we think about safety and security in the lab. So I'd be happy to send those resources over.
Yeah, that would be wonderful.
Okay.
Yeah, I appreciate that because, oftentimes, biosecurity may not be at the forefront of our day-to-day jobs, and things like pandemics and other things happening globally that now start to impact us locally. It can be, not only daunting, but one of those things. Where do I start? What are the best resources out there? Where are some of the folks like yourself that we can maybe look to for some guidance? So thank you very much. I think, again, this was a very timely talk.
Thank you. No, happy.
Thank you for all the work that you do.
Thank you.
Okay. Any other questions that might have come through while I was talking, Cynthia?
I am not seeing any.
Okay. Well, Dr. Sorrell, thank you so much for your time. Stay safe and healthy, and continue that good work that you do.
Wonderful. Actually, Denise, I'm so sorry. I do see one question from a participant asking if, sorry, it just showed up in my chat box. Have shortages in PPE stockpile been experienced in the U.S.? Had that been identified before COVID-19 during assessments? So great question, a really critical one. Yes, many times. And so what I kind of joke with my students when we talk about epidemics and pandemic preparedness from a national perspective and a global perspective is that a lot of times we do after action reports at the institutional level, at the department or agency level, and I find that they tend to be lessons observed versus lessons learned. We found a number of reports from even 2009, the H1N1 pandemic, that of course had much less of an impact nationally as well as globally in terms of human health and the economy as well as supply chains, thinking about PPE, diagnostic equipment, consumables, reagents, everything that we need to respond. There were a number of after action reports that outlined PPE shortages, face masks and protective equipment for healthcare workers, as well as individuals thinking about their protection in public spaces, as well as the shortage of ventilators. And that was called out in a number of reports, both at the government level and private sector level, to say these are going to be issues in the future and we need to invest in these. What we found out during our response when we looked at the national stockpile in response to COVID-19 was that there were a number of materials and equipment that had not been restocked. And so we thought we had X amount of ventilators in our national stockpile, and that was actually decreased by a number of thousands that just had never been replenished. And so I think that is very important when we think about assessments at the national level, at the state level, at the local level, after an event occurs, what happened and what's needed, and not only from a functional level, operational level, but politically, do we need to argue for increased budgets in order to have that stockpile renewed? At the local level, what did hospitals need that they didn't have, and make sure that is corrected for the next event. So unfortunately, this is something we've run into in the past, and I hope we don't do again, but we will see. So hopefully because this has been such a huge impact on many, many sectors, sadly, I think that aspect's going to push and promote for action in thinking about resupplying stockpiles, particularly thinking about PPE and other equipment needed to respond.
So I actually have a follow-up question on what you've just said. I'm curious to hear your input on, do you think that the national stockpile has the capability, the capacity, the surge capacity, either at the initial onset of a pandemic or in our case right now, for the continuation of a pandemic? Or do you think we have to look to really have state and perhaps the local level stockpiles as well? And regardless of where you sit on that, do you think that the country now or we can pivot to being able to supply our own stockpiles without having to look outside of our borders?
Yeah, two really important aspects to preparedness, right? So if we think about supply chain and the way that we access PPE, we learned very quickly that particularly surgical masks, a predominant number of them were manufactured in two locations, both of which were vastly impacted by the pandemic. And so, factories shut down and production wasn't occurring. And so thinking about how we can get creative about redirecting manufacturing lines in the U.S. when needed to respond to those needs, I think would be critical. Thinking about emergency situations and redirecting resources and production facilities. As a whole, thinking about how to potentially prioritize domestic approaches to the production and procurement of key public health supplies, whether those are PPE or reagents or equipment, would also be critical. And that's something that I hope comes out of these after action reports. So we think about the swabs that were needed to collect nasal specimens. A number of those swabs were actually produced in Italy, and primarily produced in one of the provinces that was heavily impacted early on from the European perspective. And so looking at how we may have just one line of supply chain for critical public health infrastructure and response systems, I think needs to be revisited. From a stockpile perspective, I do think that there needs to be assessments at the national and the state and local level. What's challenging is public health is owned and operated at the state level. So we think about budgeting for each of our states. Our state departments of health are going to look at what are the priority diseases in our area, what is our public most impacted by, and what do we need to prioritize in terms of education outreach and diagnostic capabilities. When a pandemic hits, to me, a pandemic is not a local response, it's a national response. And so thinking about how particularly the national infrastructure can support states specifically and importantly, states who may have limited budgets in their health departments and have limited infrastructure in their healthcare facilities and in their hospitals, that's when the national stockpile should be visited and allocated to those states in need. And if we can prioritize and think about how to allocate these resources effectively, that could protect not only neighboring states, but our country as a whole if we think about, the prevention of very easily transmissible diseases like SARS-CoV-2.
Yeah. I'm sorry, Lolly, go ahead.
I just wanted to see if there was another question that came in. If we've got some time, Denise, do you have some time for another?
We do. We have actually, we still have almost 13 minutes left before our lunch.
Okay. Erin, the question is, what channels do the GHS initiative answer to in the government? And then kind of just a follow on, where in the org chart is GHS placed?
Great question, and I promise I won't take 13 minutes to answer it so you guys can get to lunch early. I know it's always hard being the person in between lunch or holding you guys from having a break. So that's a great question. So the Global Health Security Agenda, when it was founded, was actually organized and overseen by a department or a directive in the National Security Council. And so they had a group that operated and prioritized global biological threats. And within that section, within the National Security Council, the Global Health Security Agenda sat and relates very closely to Health and Human Services. Saying that, a number of departments and organizations were involved not only in the creation and support of the Global Health Security Agenda, but then the implementation as well. So you will see partners across USAID, the State Department, Department of Defense, the EPA, the USDA, the FDA, all involved in Global Health Security Agenda. The office that oversaw and coordinated efforts in the Global Health Security Agenda was actually removed and destaffed a few years ago. So one of the challenges when we think about a national response is not having that office in play. It makes it challenging to coordinate all of those parties at the national level. There is hope that will come back. But at this point in time, the Health and Human Services would be the key player for the Global Health Security Agenda.
All right, thank you for that. Don't see any other questions.
Lolly, I think, I'm not sure if Dr. Sorrell answered this, but there was in the parens, where in the org chart are you?
In the org chart, am I?
Yeah, I believe that was so in addition to asking what counts the GHS initiative and with the government in parentheses, where in the org chart are you?
I am because I'm not within the U.S. government, within a department and agency. There is a group called the Global Health Security Agenda Consortium, and that's a number of non-governmental organizations that have supported implementation of a variety of action packages under the Global Health Security Agenda. So the Elizabeth R. Griffin program is a proud member of the Global Health Security Agenda Consortium.
Great. I think that answers her question. Any other questions that have come in, Lolly or Cindy? We still have time.
Not from where I can see.
Cynthia?
I'm not seeing. Let me double check here and make sure that I don't lie. I am not seeing any.
Okay, great. Well, again, Dr. Sorrell, thank you so much for taking the time today to speak with us. Again, this was really, of course, timely and very informative. So thank you again. And I think all of us appreciate the elements that you've covered in this talk and look forward to being able to look for some of those great resources that you mentioned.
Right. Well, thank you all for the opportunity. It was a pleasure being with you today. And I will be sure to send those resources over today so everyone has them right away.
Thank you so much.
Thank you.
Stay safe, stay healthy, and continue the great work that you do.
Thank you. Same to you all.
Thank you. Okay, so we're